Hello and welcome to today's episode. I have a special guest here today, Dr. Saithna. Dr. Saithna is an internationally recognized orthopedic surgeon specializing in minimally invasive knee surgeries and shoulder surgeries. His work is absolutely amazing. He is ranked in one of the top 25 global experts in ACL reconstructions, and he provides amazingly compassionate care to all of his patients. I'm absolutely honored to have him on today and for him to tell us a little bit more about him and absolutely his practice and how he connects so well with all of his patients. Thanks for coming on today.
Thanks, Amber. It's a real pleasure to be here. Actually, it's a particular pleasure because you recently looked after some of my patients and the feedback I had was also excellent.
Thank you.
I know you went really out of your way to help one particular patient, and that was very much appreciated by them and me. So, I think that's a great start to this podcast to just tell everyone how awesome you are.
Thank you so much. Yeah. Did he tell you that did you see his pink walker?
I did.
I needed to get him a walker and it happened to come out. The box looked red, but when I pulled it out, it was hot pink.
He actually
he loved it.
He was very grateful just to have the assistance. So yeah. I think he wasn't bothered about the color.
No, he wasn't. He loved it. So I just got to meet you a couple of months ago, and it was actually at a networking event for your practice. So tell me a little bit about your practice, when it started, and how you actually came to work for them.
So I've actually been in practice for about 10 years, 5 years in the UK, and then coming up to 5 years in the US. I've been in Arizona for just over 2 years. And my practice is specifically focused on orthopedic sports medicine, which is basically minimally invasive knee and shoulder surgery. Although we call it sports medicine, actually many of my patients are non-athletic, and a large proportion of my patients are actually sedentary and don't do any kind of athletic activity. So sports medicine is a term that we really use for minimally invasive and arthroscopic surgery. But my practice includes both very athletic patients. In the last year, I've seen several Olympic athletes and also elderly patients who just want to get back to doing normal activities of daily living in a pain-free manner. For the shoulder, I do lots of rotator cuff surgery, instability surgery, which is basically people who recurrently dislocate their shoulder, biceps-related problems, shoulder impingement. And then for the knee, I really specialize in ACL injuries and meniscal tears, cartilage repair type procedures. But anything knee or shoulder that requires sports medicine type care, minimally invasive surgery, I focus on that. I don't do any joint replacement surgery. So people who have severe arthritis, who need a knee replacement or a shoulder replacement, although many of them come to me to try and avoid surgery with non-surgical treatment options, I don't actually do a shoulder replacement or a knee replacement for them. But we have lots of other options if they want to avoid surgery.
So people don't know what that means when you say minimally invasive. Do you mind describing a little bit about what that actually means for a surgical candidate? So somebody comes in, they have pain in their joint, they're really not sure what to do, and they're considering surgery. What is the difference between a minimally invasive surgery and, for example, like an open surgery or a total surgery?
Yeah, so a really great example of that is rotator cuff pathology. So the rotator cuff is a bunch of tendons in the shoulder. Most people probably know or are familiar with the term because the pathology is so common. Over the age of 50, most people will present to their primary care physician at some point in their lifetime for a shoulder-related complaint, and the most frequent pathology is the rotator cuff tendons. So historically, this surgery's been done open, and for those of you who are not just listening and looking, it's basically an incision like this would be made on the outside of the shoulder.
So a couple of inches right on the front of the shoulder, and he's making an incision like longitudinally down your arm.
Yeah, and then we would actually have to split and spread the deltoid muscle, maybe even detach a small part from its bony attachment.
It's like opening it up with forceps. He's kind of looking in toward the bone.
Yeah, and then down to the tendon and repair it. And so that obviously means disrupting the deltoid muscle, which is actually very important in the rehab after these kind of injuries. The deltoid muscle is good in the first place, so the last thing we want to do is actually to disrupt it and have to slow down the rehab for that to recover from the surgery. So in contrast, what we do now is minimally invasive surgery or arthroscopic surgery, and that means making very small incisions, typically 5 millimeters or less in size, and we use those to put instruments and a camera inside the joint. And actually that gives us much better visualization than an open procedure anyway. And it's very less invasive. There's no significant damage to the deltoid muscle, so we speed up the recovery of that. And also when we have smaller incisions, things like the risk of infection are lower as well. And so we can see better, we can do the surgery better, and it's just quicker recovery for the patient overall.
Yeah, that's always fantastic when we can see that. Everybody wants to know, how long am I going to be down if I get these surgeries? And something that I find as a physical therapist is that sometimes people aren't prepped well if they've come from some organization that didn't do good prep on what's going to happen after my surgery. So they know they need surgery. They know there's some kind of rehab involved afterward. But what do you do a little bit differently to help prepare your patients? Because the people that I've seen are very well prepared. They actually know which week they're going to start progressing to toe touch or 25% or weight bearing as tolerated. They have an expectation in their mind, and they don't know exactly what they're supposed to do, maybe in each phase, which that's my job, but they know a general timeline of when they're going to be kind of back on their feet or expected to be, as long as everything's going well. So tell me about how you make that experience better for your patients.
Yeah, absolutely. It's super important that patients understand their rehabilitation and recovery. Firstly, because it's motivating. It's almost like gamifying the process, which we know is incentivizing to patients. If they know they're on track or they're doing a little bit better than other people who've undergone the surgery, then that motivates them. And, we all know about the placebo effect. And so it just shows that the psychological aspect of what we do is very important. And maybe in the past we haven't been very good at that. But I think now we really focus on it, and we want to make sure that patients understand their treatment well, they understand the recovery process, and they have milestones that they can focus on to achieve. I also think it's very important to individualize the rehabilitation. So I don't have a blanket rehabilitation protocol for my patients. It's individualized to exactly their needs. And one really good example of that, which we're actually discussing just a few minutes before we started the podcast, is with rotator cuff repairs. So typically for someone who's had a rotator cuff repair, they would be in a sling for about 5 or 6 weeks after the surgery. But we have an option now where we actually can avoid a traditional style rotator cuff repair in some patients. So patients who have a partial rotator cuff tear, historically there would be 2 options. One would be to complete that tear, make it a full tear, and then fix it back, or to do an in situ repair where we make small holes in the tendon and fix it back to the bone. Both of those have some disadvantages associated with them, and the main one being that they may have a bit more stiffness or pain than other types of patient. But now we have a really good option where we can actually put a collagen patch directly onto the tendon, so we don't have to do a traditional style repair, and that really speeds up their rehabilitation. So instead of 5 or 6 weeks in a sling, they're only in a sling for 2 weeks, and that's a huge
is massive.
A bonus for the patients. Mm-hmm. They have way less pain, much better movement, and the recovery is just way easier. It's totally different to a typical rotator cuff repair patient, but there's only certain patients who that is appropriate for, and obviously that's individualized.
So this is something that definitely separates you from a lot of, I think, your peers here in the US, is it's not just you're an orthopedic surgeon, you're also a professor. Dr. Saithna also has over 200 published articles. This is a man that is highly invested in educating other people in making sure that his outcomes are absolutely fantastic, and that he's a forerunner in what's going on in the human body and the orthopedic joint. So talk to me a little bit about your journey with that. Is that something that's so incredibly important to you and that's why you did it? Or did you kind of fall into, I know that I have some skill set, just even the way that you speak is easy to understand, I think, for most people. You connect with people, you're good at communicating. So did that lead you into education and lead you into research? Because I actually found the opposite to be true, that a lot of people that weren't as good as communicating were a little bit better at looking at data, maybe. And so, I see this, that you have multiple skill sets, and what drove you that direction?
Well, I appreciate the kind words. I think a lot of it has to do with the English accent. It just makes you sound a lot more intelligent.
It's an unfair advantage. Accent bias.
But I didn't really recognize I had a particular skill set for research or anything before I got into it. I was actually lucky enough to have a really good mentor And just like with most things in life, the direction that you take, especially professionally, is often guided by your mentors and people who inspire you. And that's actually what happened to me. So while I was in medical school in the UK, we do this thing called an elective, where you basically spend a few weeks out of the country, typically in a center of excellence, learning about something that they do. And I happened to spend some time focusing on bone tumors. And that was something I was really excited by at that time, because the surgery is some of the most incredible orthopedic surgery that they do. And they deal with some really complex problems. So I just found it very exciting. I didn't actually go into that particular thing with an interest to do any research. I just thought the surgery was incredible and interesting. But I lucked out because my mentor was one of the most well-recognized orthopedic bone tumor surgeons in the world. And, often when you meet someone with such a big reputation, you can be intimidated or find it difficult to connect with them. But he was the most down-to-earth, super nice guy. And he really mentored me amazingly, to the point where he actually, even as a student, I didn't have any money. He actually bought me a laptop so I could do some research. It was that level of
investment in your education,
in me as just one of the many medical students that he would see. So obviously that was very inspirational for me. But what was very cool from a research perspective was that the study we did was to compare the outcomes of osteosarcoma, which is a bone tumor that typically occurs in young children. And we compared the outcomes in the UK to Italy and the rest of Europe. And what we found was that patients in the UK were actually doing worse, which means that unfortunately they were not surviving as well as patients in Europe. And what our research did was demonstrate that that was likely due to chemotherapy in the UK. And so although my work didn't directly change the chemotherapy, it led to other work that ended up changing the chemotherapy in the UK and improving survival of patients with those tumors.
Wow.
And for me, that was amazing, because I was a medical student and already I had this huge impact on patients and families that I would never meet. And so that really inspired me to go beyond just my normal day-to-day practice of helping the patients I see. So, I just felt that was something really fantastic that I could contribute, basically. So that started me on my journey to research.
That is absolutely fantastic. So I do oncology care as well as neurology care, and I do orthopedics and geriatrics. But I find that oncology care, neurology care, because I'm only in patient care, are the most impactful for me. They're the stories that stick in my mind the most. And the fact that you were able to reach that times 100,000, that your interest in learning something a little bit better and diving into the information that was already there, right? So sometimes people don't really understand how research can be done. So a lot of your research is basically looking at a lot of information over a whole plethora of different kinds of studies that have already been done. Can you talk about that for people that don't really understand how medicine learns from itself? Like what is, how do you do that?
There's many different ways in which we can use research to kind of help us improve patient care, which is basically what it's all about. Yep. We want to get better outcomes for our patients. And so, as you say, there's already a whole bunch of research out there. So one way that we can kind of better harness the existing knowledge is that there may be a particular topic we're interested in, and there might be 10 studies already looking at that, but they're designed in different ways.
And each of those can have hundreds, thousands, tens of thousands of patients inside of them already with data that has been already taken.
For sure. And we can statistically combine some of those studies and pull the data to give us a much more powerful answer to the question that we have. So, excuse me, one really good example of how we did this recently was that if we do an ACL reconstruction, so the ACL is a ligament in the knee that's very frequently injured during athletic activity. And when we reconstruct it, there's a risk of infection. But that risk of infection is extremely small. It's 1 in thousands of patients. And therefore, to study that risk, we need a huge, huge population so that we have enough numbers to show a statistical difference. And so we recently published the largest meta-analysis on this topic. And meta-analysis basically means that we pull data from previous studies. We also included some new data from our own centers and pulled it. And we have the largest published study on this topic. And what we've demonstrated is that it's highly effective to add an antibiotic to the graft at the time of surgery, and that significantly reduces the rate of infection. Even though it's a rare complication, we're very interested in it, because if you get that complication, the likelihood of you having a bad outcome of your knee in the long term is much higher. So we really want to avoid it, even though it's rare. And that's why without this pooling of data, the alternative way of studying this topic would be to do a multi-center study or a trial over an extended period of time to collect the data. And that becomes unfeasible, basically. No one has the resources to kind of study that. So the best way to do it is to pull previous studies. And that's one example of how we do it.
So there is something extra special as well about your ACL research and your ACL surgeries that you're continuing to make sure that other people know about, surgeons know about, your patients know about. So one of the things is that when you get it, I actually had an ACL repair and it didn't go very well.
It wasn't me.
It was definitely not Dr. Saithna. And I had a very atypical complication during surgery where while I was under anesthesia, I was told that I had a muscle contraction and they lost my own hamstring graft and they needed 2 of them. So they had to go in and search for it first. And then they were unable to acquire the missing one. So they took one out of my other leg as well. And I have a lot of stretch, I guess, laxity in my other knee. So they decided that they were going to put this one in really tight as well. My rehab process didn't go that well. And that's actually something that inspired me was no one ever called me out for not doing what I'm supposed to be doing. Nobody ever said, hey, it really, I mean, I was 18 and I really didn't understand how important it was for me, myself, to understand my own body and speak up for myself and do my own homework. I just didn't. I guess I was just at that point. When I see people who are advancing things so quickly, or that they're doing something that really has such an impact on something that's done so frequently. ACL repairs are they're a really common knee surgery, especially for athletic individuals. But nobody really understands what the importance of the ACL, what it actually does. And it's a checkpoint. It's a checkpoint for motion going forward. So if I'm going downstairs, my ACL is a checkpoint for me actually not falling and collapsing when I go forward or I move my body and turn it. That could be simply just pivoting off of my foot or turning to the side. It could be going downstairs. It could be going downhill. It could be going to sit on the floor. And so one of the things that makes your surgery more successful is that you aren't just looking at the ACL. You're looking at the ALL as well. So would you like to talk to that a little bit about why your surgeries are more successful and your outcomes longitudinally are more successful?
Yeah, for sure. So I think to start off with, I would say that we should differentiate between ACL reconstruction and repair. Repair is a process where we actually fix the native tissue back. And if we have time, I'd love to talk about that more. But reconstruction is kind of the gold standard, which is what the majority of patients get. And that's where we harvest a graft, a bit like where you had your hamstrings harvested and use that to make a new ACL. Mm-hmm. So what I do different is something called an anterolateral ligament reconstruction or a lateral extra-articular tenodesis. And the easiest way to think about it is basically that, just as you described, the ACL is a structure at the middle of the knee. And what it does is it controls the anterior and posterior movement of the tibia, but it also has an important role in controlling rotation of the knee. And so if we think about when we drive, we all drive one-handed all the time. We shouldn't, but we do. But when we drive one-handed, we can hold the steering wheel on the outside of the steering wheel with just 2 fingers and a light grip, and we have really good control. But we would never dream of holding the steering wheel in the middle and trying to control it like this because it would be really hard to control. Yet that's what we're asking the ACL to do. When we do an ACL reconstruction, the ACL is at the center of the knee, and we're asking it to control rotation of the knee. Now, in the uninjured knee, that's totally fine. It works great. But in an ACL injured knee, it's very rare that it's an isolated ACL injury and there's other things going on. So unless we deal with all of those, doing an isolated ACL reconstruction is equivalent to holding the steering wheel in the middle and not really having great control. What we do on the outside part of the knee is an extra procedure, either an anterolateral ligament reconstruction or something called a modified lemare. And what that does is reinforce the outside part of the knee. It's equivalent to holding the steering wheel with 2 fingers on the edge. It's a very small, minimally invasive procedure, but it significantly improves the rotational control of the knee. And this is an area I've been interested in for the last 10 years. I've won numerous awards from the Arthroscopy Association in North America, the Royal College of Surgeons in England, because of the impact of this work. One of our key landmark studies was actually one of the most highly cited articles in the last 50 years in the American Journal of Sports Medicine, which is the biggest sports medicine journal in orthopedics. So the key finding, or the key reason we do this, is because it reduces the graft rupture rate. Now, anyone who's involved with young female athletes, particularly pivoting and twisting contact sports, let's take female soccer players. Mm-hmm. If you've ever worked with female soccer players, you know that the ACL injury rate is high. But not only that, but once they've had an ACL reconstruction, the re-injury rate is very high, 30% across many, many series. So what we do by adding this additional procedure on the outside part of the knee is we share load with the reconstructed ACL graft while it's healing. And we also more normally restore knee kinematics. Kinematics is basically a term describing the way in which the knee moves normally. And in a knee that's got an isolated ACL reconstruction, we can't reconstruct that normally. They still have residual translation of their knee and rotation that's abnormal and stresses the graft. So by adding this additional procedure, we more reliably reconstruct and replicate the way in which the knee is designed to move. And so that reduces stress on the healing ACL graft. So our graft rupture rates are significantly lower, 3 to 5 times lower. In multiple populations, we've demonstrated this. Actually, it's very exciting because just a few weeks ago, I was in New Orleans for the Arthroscopy Association of North America conference. And there I presented the world's largest series on this particular topic. And it's particularly exciting because we compared combined reconstructions, ACL plus an ALL reconstruction with hamstring tendons, compared to isolated reconstructions with a BTB graft. And historically, the BTB graft, which is basically part of your patellar tendon, a little bit of bone from the patella, a little bit of bone from the tibia, that's historically been thought of as the gold standard. But what we demonstrated in a large series of over 2,000 patients was that if you have a combined reconstruction with hamstrings, you have a 3-fold reduced risk of graft rupture. And that applies not just to the overall population, but specifically to young patients in high-risk categories as well, that young female soccer player. Mm-hmm. And traditionally, these patients have often had a BTB graft, and I'm sure you'll have seen patients with significant adverse outcomes after that kind of procedure. They often have knee stiffness, they often have anterior knee pain, they can't kneel down, they still have the same issues with graft rupture rates, reoperation for secondary meniscectomy. So it's not really a good gold standard, and we're demonstrating for the first time with really good high volume data, clinical results with long-term follow-up, that actually combined reconstructions are significantly better.
So I think that this really kind of wraps it up for me. One, you have absolutely exceptional work, but it's really founded in all the research that you do, because you really are trying to move your entire profession forward for the benefit of the patient in front of you, for the benefit of every patient that you really can't get your hands on as well. So I'm more and more impressed the more that I learn about your career, the things that you choose to spend your time on. To bring it back to the personal side, what do you have time for outside of all this research you do? I know you have a beautiful wife, Gia. What do you love spending your time on outside of surgery and outside of patient care?
I love being active and outdoors. So one of the reasons we live in Arizona, there's many reasons, but one of the reasons we live in Arizona is I just love the wildlife. We're up in Cave Creek. Yes. Last year I had a really amazing experience. We had some owls nesting nearby in a cactus, and I basically got to see them every day, the little owl babies or chicks growing up. And the really cool thing I got to see was I saw them actually fledge. And what that means is that they learn to fly. They leave the nest and learn to fly. But I actually got to see the process. And what they do is when they first learn to fly, they basically jump out of the nest and they can't really fly. So they basically descend down to the ground. And then they can't fly to get back up either. So they have to climb up. So I have a video of them climbing up a tree and then practicing jumping down and flying again. It was just the most incredible experience. So, and I have some really awesome photos. So, and we get to see loads of other wildlife too, but that was particularly cool. And
That's
then
awesome.
Both my wife and I like hiking. I like cycling a lot, or road cycling.
You actually have a really impressive cycling. Well, you did a lot of cycling previously, right? Before you moved to Arizona?
Yeah. So I had a sports scholarship for Ironman triathlon at university. So that was really my background. And then I had some knee surgery myself, actually. And I think it went pretty well. I was able to get back to competitive cycling afterwards, but not so much running. So after I had my knee surgery, I had probably 5 or 6 years where I really focused a lot of my time outside of work on competitive cycling. And I competed in Canada and in the UK, and that was mainly in cycling time trials and road racing. Mm-hmm. And then I also just like cycling just to be outdoors, and I love the mountains and the scenery. So Arizona's great for that too.
Didn't you actually cycle the Tour de France tour?
Yeah. So
not in the race, but the track.
Not in the race, but in 2012, me and 3 friends cycled the full route of the Tour de France. It's 3,500 kilometers in 21 days. We did exactly the same route as the pros, and we did it in exactly the same number of days as the pros as well. But the difference was obviously we're not as fit by a long way. And also, if you know about cycling, you know that 70% of the energy you use in cycling is to overcome aerodynamic drag. And so when the pros are racing together, there's a whole big bunch of them, and it's actually a lot easier for them because there's a big bunch of people.
They're like drafting off of each other.
Yeah, they're drafting off of each other. It's much more protected. But there was only 4 of us, and so we don't have that same benefit. Yeah, we can do it a bit, but it's nowhere near the same as being in a big group. And the other challenge we had was, there was a lot of challenges, but one was that I was still in residency at that time, and I was actually doing my trauma block. And what that meant was that 1 week a month I was working 120 hours, and on the quiet weeks I was working about 60 or 70 hours. So all I had time for in build up to this was go to work and cycle and eat and sleep, and that was it. I didn't do anything else. And so that was I couldn't, even despite that, I still couldn't train as much as I wanted to, but obviously I got fit enough to be able to do the event just fine. But some of the challenges we had were, as a pro, if it took them 6 hours to do a stage, it might take us 8 or 9, depending on the terrain, wind conditions, that kind of thing. But we were spending a lot more time cycling than the pros were. And what some people don't recognize is that at the end of each stage, you don't normally start the next day in the same place. You might have to drive 100 kilometers to the next stage. And so we had to finish cycling, we had to eat, have a shower, get to the next spot and sleep, and then be ready to start the next day on time to be able to finish that stage. So it was basically nonstop, but I was super lucky because we had a support crew of about 10 or 11 friends, not all of them with us at the same time, but over the course of the 21 days, we had a whole bunch of friends helping us out, and they took care of everything: laundry, cooking food, driving. So, me and my 3 friends who actually cycled, all we had to do was wake up and ride our bikes. So it was a really good team effort. And actually we did it for charity and raised a lot of money for lymphoma and leukemia research.
That's fantastic. Thanks for doing that. That's absolutely wonderful. So you cycle, you're doing surgery. When you are actually meeting with people, I mentioned this before, you have just like an actual natural way to communicate and connect with them. Do you think that that's one of the primary reasons your patients are so incredibly satisfied? Because I've read you have, I mean, even just your personal Google as a physician, which is absolutely insane to see. I saw nothing but pure satisfaction and excellence. People literally said, I hope that I never have to see him again for this, but if I did, there's no way I wouldn't come back to see you. I mean, it was just absolutely phenomenal to see a physician that communicates well, impresses his patients, has outstanding outcomes that people would literally want to come see if you weren't doing surgery.
Yeah, I think, obviously communication is super important, but I think there's lots of factors. I think one of the most important to me is that this is how I get my satisfaction, is by being good at what I do. And there's really nothing more satisfying for me than seeing a patient who's, severely injured, and making me being able to do a surgery and get them back to doing the things that they love. That's it's really rewarding, especially for patients who are highly athletic, because that's the best test of what we do.
Like the return to full function.
Yeah. Obviously, it's very rewarding to get the average person back to doing recreational sports. But as a true test of what we do, if we can get that elite athlete back to their same pre-injury level of competition that they had before injury, that's the ultimate test of what we do. And so that's extremely rewarding. But at the same time, I get just the same satisfaction from, helping the elderly patient who is struggling with their activities of daily living to getting back to being able to do things pain-free. So for me, that's one of the driving forces. And I think that, that's why I have good patient satisfaction, because I individualize treatment to patients. I understand what their goals are, and I do my best to get them back to doing those things. And when I say my best, I mean that, obviously being a physician involves a lot of training, but as we spoke about all my research, I've really done a lot of additional stuff that I feel puts me in a better position to give that patient the best possible care that they could have. And I think that really impacts their outcomes. The other aspect of it is that I get so frustrated when I hear patients say that they have been to a physician's office, or when a family or a member of mine or a friend of mine has an experience where they go to an office and they're treated with, unfriendly staff or a grumpy attitude. Because again, we come back to the placebo thing we were discussing right at the beginning. If you go there and someone has a bad attitude with you, you know immediately that they don't really care about you. And so that's going to affect the outcomes of treatment. Mm-hmm. So I have a philosophy that I want to treat every patient of mine in the same way that I would want a member of my family to be treated. And my clinic staff also are really caring and compassionate. And when you read my reviews, you probably have seen that lots of people also commented on my my office staff too.
Yes.
And they really care about my patients, and they do a great job with them. And I think that those are the kind of three main aspects that help to get patients back to doing the things they love, but in a compassionate, caring way. That means that patient satisfaction is very high.
I think that makes every difference for any patient that's going in, or customer, I guess, of any practice. The very first face that you see can often have a massive impact on if you are ready to walk out or you're actually going to stay there. I commonly hear this thing that we say here is like, oh, well, they don't have great bedside manner, but they're a great surgeon. And to me, those two things, I don't understand how people separate them, quite honestly, from myself. I think that you trust people that treat you well, that want what you want. So you're focused on the outcome. You're focused on the individual in front of you. I also come from my very first job was in an Italian restaurant, and they said, treat everyone in here like you're serving your grandmother. If they're cold, you can go get their blanket out of their car. If they want a special kind of dressing, walk over to Fry's and pay for it and come back and we'll reimburse you. Like, it was very focused on the person's experience right in front of them. They were the most important for your time and your effort right at that moment. I think I've tried to carry that through, and I think it's actually really rare to find someone who is in your position as a surgeon that people find to be so incredibly friendly just across the board. And I have no doubt that it's one of the reasons that you're so successful on a patient to patient level. And then also just being able to share your information and share your skill set and network with other providers. I think that it's something that definitely separates you. So I just want to say thank you very much for your contribution.
It's a team effort. And, thank you to you as well, because we mentioned earlier the example of the patient that you went out of your way to really help. And obviously I'm not going to give patient specifics, but what you did for my patient, I don't think that there's many other providers who would have done that. And, when I heard that story, I knew that I'm going to, build a really great relationship with you, because you have the same mindset as me. And it's really about doing the best possible for our patients.
Thank you. Thank you so much. It's been an absolute pleasure to have you on the show. If you would like to find Dr. Saithna, where do you currently work? How do we get in contact with you and find out more?
So I have 3 locations across the valley. My main office is North Scottsdale, so that's Pinnacle Peak and Hayden. Then we have a location in the West Valley, which is 101 and Thomas, and another one in Central Phoenix, which is very close to here, which is right at Papago Medical Park. You can call my office for an appointment on 602-266-2272. And if you want more information about me, you can access my website. Just type in my name into Google and it will come up. It's Adnan Saithna. So that's Adnan Saithna, Saithna.
Well, thank you so much for taking time out of your busy day today. And thank you so much. You were fantastic to have on.
Thank you. I appreciate it. And thanks to the technical team back there as well. Really appreciate it.
Thanks, Goo Media.